afternoon, everyone. Uh, Welcome to webinar number 16 of the Patient Support Group on behalf of the Indian Society of Blood and Marrow Transplantation. As you are aware, we address these meetings so that more and more patients can benefit in making informed choices and decisions and get all the help that they need in their journey towards a curative bone marrow transplantation. Today, the topic of discussion is funding opportunities for bone marrow transplantation, which is useful for almost all our patients. I am Dr. Venkatesh Ikoti. I will be hosting this webinar session for you on behalf of our sponsors. On behalf of ISBMT, I thank our sponsors, Genova and Novartis, for making this meeting possible. Today, to talk to us for the next half an hour, I would like to invite our esteemed faculty on behalf of ISBMT, uh, members and mentors, uh, Mr. Kenson Sam Alex, medical social worker and BMT coordinator at St. John's Medical College Hospital, Bangalore. He'll be talking to us about funding opportunities. I also want to thank our mentors, Dr. Tapan Saikya, Dr. Revati Raj ma'am, and Dr. Shashi Apte from ISBMT, and all our members, board members of ISBMT, including Dr. Silki Jain, who have been constant part of this webinar series. Over to you, Mr. Kenson, for your delivering your talk.
So, good afternoon to one and all. It's a great pleasure and privilege for me to do my session in this webinar, and I'm thankful to the ISBMT team as well as all the office bearers for inviting me for this session. And also, I would like to thank Revati ma'am, Rashmi ma'am, and also Shobatali ma'am for considering me for this session. And it's a great privilege and an honor. I felt so privileged, and I would like to share my screen right now. So I hope the slides are visible.
Yeah, it is visible, sir. Good to go.
Yeah. So, as you know, my name is Kenson Samlis. I'm a medical social worker and bone marrow transplant coordinator at St. John's. I also carry a couple of other responsibilities here. I am looking after the INFOG, all the researchers. So I'm working as a CRC as well as the data manager for St. John's since 2019 November. And over the period, I was privileged to look after a lot of children along with the bone marrow transplant patients. So I think my little expertise in this area will be beneficial for all the listeners. So over to the slides. So as we all know that BMT is now something which is happening across the country where the interest is more in that area as well as the needs are more. But to find the funding support, it's quite a big Himalayan task. Where we all know that BMT is an expensive thing. It varies between 12 to 35 lakhs across the country, depending upon the center that we are doing the thing. I haven't included the autologous, the autologous transplant cost around 7-8 lakhs, depends on the center. But often it involves a long-term care because it's not just the procedure that the patient goes through or the family goes through, but it's a lot of logistical aspects are there in the case of bone marrow transplant because we have to plan very early. And early means in the aspect when the medical team, considering the medical team, they have to plan very early. If it's a malignant case, they have to see what's the prognosis and how the patient responding to the chemo. If it's a relapse, then planning for a BMT. If it's a non-malignant case, if it's anything like bone marrow failure syndromes kind of disease, then they have to plan little faster, find a donor. So a lot of things are there. Along with that, funding is a major challenge because we are in a country where majority of the patients or people doesn't have health insurance. Very few of the entire population have a personal health insurance coverage, and also it always it's a huge burden for the family. So when why we need funding support in order to reduce the burden or the stress on families because already they are going through a lot of stress knowing how the child is going to survive, is the child going to come out of this thing, and there are a lot of systems connected with the child. So as a family, as a whole system, they are extremely fragile and those movements. So funding is always a major concern for them. So finding good funding support will help the family to reduce those burdens, as well as helps the treating team as well to go forward and also give more comprehensive care. That's one of the primary thing. And definitely when it comes to funding strategies, definitely I will tell over last 6 years, for most of the time, it's all about planning properly. It's not just like a 1 day's job or 2 days job. So we have to see what are the criteria coming when it comes for funding. When the primary thing is like how the family's eligibility. Eligibility criteria is a major thing. So check if the patient is eligible for any central government schemes. And the next comes like if they're not having enough documentation or they're not able to get central government schemes, try for the state government schemes. And also we have to make sure the hospital empanelment. That's a major concern even with the center I'm working, St. John's Medical College. We often have not able to find that empanelment opposition. So we have PMJY, all the schemes in between Ayushman Bharat, but still some of the major schemes we are not able to get empaneled. So where the patient is taking the treatment, is the hospital empaneled for that scheme? That's a major concern. And also when it comes to financial support, it's not just central government or state government, but it also comes with lot of NGOs and philanthropic activities, as well as the, I think post-COVID era, we all are much familiar with crowdfunding platforms. So those kind of various plans and programs we have to implement. And these are various areas that as a family, as a treating team, as a social worker or a BMT coordinator, we have to guide the patient and their family to get the funds. And also having a proper database. We should plan it early. We should have proper data. We should know where to apply, who is going to give how much, and who is going to give this. Like we should have a proper plan. So that's a major key part in funding strategy for BMT. And when it comes to types of funding, we all know this other some of the fundings like government schemes are there, and NGOs and trusts for individuals, and crowdfunding, which is doing a major part, and also some CSR support, and some hospital have their own supporting mechanisms, and as well as insurance. So these are the few areas where a patient can find some support while coming to the situation of a BMT. So I think when we go to state level government schemes, we have each in India, all the states have their own kind of schemes, and often it's implemented by each states, and it has its own variations here and there. But not all hospitals in every state are empaneled for that BMT program, as I have mentioned earlier. So that's always a tricky area when it comes to government scheme. There are funds, but to channelize those funds, it's always a challenge. But still, and also what I've seen is that often this cancer or hematology transplants are often explored. Not too much funds are allocated for transplants in some scenarios of some states. And also the support from government will not be enough to take over the entire BMT area, and also not just BMT, then post BMT care. And also, it's always almost 4 to 5 weeks of entire thing. So then the BMT support provided by the state schemes might not be enough to support the entire thing. And also we before applying, we should essentially we have to verify the package, because it's all having a package code, and we have to verify the what is the package is providing. There are also definitive like rules and regulations and guidance for each package. When it comes to the Ayushman Bharat scheme, I have experienced that with a couple of patients. When it comes to those each package numbers, it's a code number, and the code number specifically tells it's for this purpose. Anything outside that, it's not covered. So it's always a tricky thing when it comes to state level government schemes. But I think I would like to take you through a couple of state level government schemes, which is across the country, and some are not specific. Like when it comes to the state of Delhi, Delhi doesn't have a specific BMT program, but the state have a 360-degree cover, which is always it's considered as a comprehensive healthcare model. And BMT coverage must be varied by each case. The state of government have to take each case into consideration, and they have to give approvals to that. And when it comes to West Bengal, we know that state health coverage, the Swasthya Sathi program is there. So that also doesn't have full coverage but still they will be giving partial coverage, as well as the West Bengal's Chief Minister Distress Relief from West Bengal. They have a minimum assurance of 1 lakh rupees support for any patient who submits the documents. That is the scenario with West Bengal. And when it comes to Assam, it's Adal Amrit Abhiyan. Like it covers high cost diseases, including cancer, and also this will be provided for BMT as well. But one more thing, again, the scenario comes is that it doesn't cover fully. So, but this scheme is something which can be used for us patients from Assam. I'm just telling about the state level schemes. And when it comes to Madhya Pradesh, it's called Deen Dayal Upachar Yojana. So it's a it provides a secondary and tertiary care coverage, and also high-end procedures like BMT often needs support from PMJ as well towards, and also matters when is the hospital is empaneled for the scheme. And Bihar, that PMJY is little tricky area in that area where Bihar does not have a high cost independent state scheme. So all the eligible families primarily rely on Ayushman Bharat PMJY, and often we have told before that PMJY doesn't have much of an codes uh, available for bone marrow transplants. And when it comes to Tamil Nadu, the Tamil Nadu's Chief Minister's Comprehensive Health Insurance Scheme, Kalanger scheme, we'll call it that. That's a very scheme which the state of Tamil Nadu implements, where they'll get, for match sibling transplants, they'll get 10 lakh rupees support. And for unrelated donor, for haplo transplants, they'll get up to 15 lakhs support. The only criteria will be the family should carry a ration card and adequate documents like Aadhaar card and all these things. So families often can get this support from Tamil Nadu. And when it comes to Kerala, it's Karunya Arogya Suraksha Padhati. Up to 5 lakhs is what it's supported. And even in some couple of cases where last year, one of the patient came from Kerala who got Chief Minister's Distress Relief Fund. Almost 70% of the entire BMT cost was reimbursed to the family. So that's also provided with adequate medical summary, with the transplant protocol being shared to the authorities, along with the medical summary, with the diagnostic reports, with the proper documentations from the family. The patients can get it as a reimbursement. One thing is that most of the schemes, some of the schemes comes like a credit scheme, where the family doesn't have to pay anything to the hospital. But in some other scenarios, it will work like a reimbursement program. So the family have to spend the cost there with the help of NGOs or individuals or something like that. And then the family have to submit the entire bills along with the discharge summary and other documents, where the hospital have to submit a no due certificate to the authorities. With all these documents, the family will get the reimbursement. And when it comes to Andhra Pradesh, the state of Andhra Pradesh have this YSR Arogyasri. Arogyasri has been like being a person from Bangalore, and many hospitals in Bangalore is having this Arogyasri scheme, and this scheme is supporting patients. I believe not fully for BMT, but still the scheme have some codes which is specifically mentioned for bone marrow transplant programs. So that's quite helpful for the patients there. And when it comes to Punjab, it's Mukhyamantri Punjab Cancer Rahat Kosh. It's just a scheme there, but for BMT related support, it's case specific. They have to submit the patient case to the authorities, just like we know in case of ESI. It's a case specific support is provided by ESI across the country, where the approval comes from the central government side. So in the same scenario, in Punjab, this is the case. The other approving authority have to consider each case separately, and they will approve it according to the eligibility. And then when it comes to Maharashtra, it's called MJPJY scheme. It also comes under the PMJY scheme as well as, but the state of Maharashtra have few codes to support the schemes, but not completely covering the bone marrow transplant coordinate. So all these schemes are just partially supporting the patients. And when it comes to Rajasthan, it is Mukhyamantri Ayushman Arogya Yojana. Before it was BSBY program, but now it is Mukhyamantri Ayushman Arogya Yojana. It's also an integrated way of state scheme joining with the PMJY, the Central Ayushman Bharat program of the central government. They're providing few codes for BMT, but not fully covered. And we are, as we all know, that there are schemes like the Rashtriya Arogya Nidhi scheme and also Health Minister's Cancer Patient Fund as well as, where poor patients will get financial support, and also depending upon their documentation. Documentation is a key fact where some of the patients, even some cancer patients, will get up to 15 lakhs to do their bone marrow transplants. But still, as I've told in my initial slide, sometimes the hematology cases, often the names like thalassemia or aplastic anemia or ITPs, these kind of any such hematological conditions are often missed in this all this state government and central government schemes that what I have shown, especially in the Ayushman Bharat PMJY. That is a fact. So these kind, though all these state schemes are there to support, but when it comes to central government schemes, where we all know that Coal India Thalassemia Balance Yojana, which is a huge support for many families across the country as well as for many hospitals who is trying to get into empanelment of this thing. So this is a scheme where it supports for thalassemia as well as aplastic anemia. So it's also once again it comes with the empanelment of the hospital. If the hospital is empaneled for the scheme, it will definitely help the family and to cut a lot of their cost, because that's a huge amount that's provided by Thalassemia Bal Seva Yojana scheme. And also it also provides where I have seen this is some of the schemes always provide support only for specific, like some specific tests, some specific procedures. But the schemes should always be a whole coverage where it will cover all the areas as well as hospital stay, beds, all the transplant procedure, post-transplant care, supportive care, all these things. So I think Bal Seva Yojana is a very good scheme in that. And when it comes to Ayushman Bharat, that's a scheme where it covers up to 5 lakhs per year. So often all the central state governments have connected their state program with this Ayushman Bharat, where Ayushman Bharat is the umbrella term for the entire country. When it comes to each state, it is different. Like in Karnataka, it is Arogya Karnataka. It is in Arogya Shri in Andhra Pradesh. It is Arogya Kerala in Tamil Nadu. Likewise, this is varying from each state to the state. But that's a primary scheme which is supporting all these small state schemes. And when it comes to Prime Minister's National Relief Fund, that's something that we know it's a reimbursement program. Often some of the hospitals have uh, credit facilities as well. Some of the hospitals have credit facilities for PMNRF where the hospital is already empaneled for providing credit support, where the families have to submit the estimate letter, the diagnosis report along with their Aadhaar card, ration card, and other income certificates, as well as MP's recommendation letter. That's a key point. MP's recommendation letter, they have to send it to the Prime Minister's office. And once the Prime Minister's office receives this, they will send an approval letter. The hospital empanel for credit facility, they will take this approval letter and they will provide treatment up to the amount mentioned in that. Usually it will be varying from 1 to 3 lakhs. And in in other cases where it's a reimbursement scenario, the family or the hospital, somehow the bills have to be cleared, then the original bills have to be submitted. The initial part where the getting the approval letter is the same thing for reimbursement and credit program, where they have to apply, they have to get the credit letter, approval letter. After that, the approval letter has 2 years validity. So from that, for within the 2 years, whatever treatments are happening or medicines or the bills are incurring for the patient, they can accumulate it together and it has to be sent to Delhi. And once the bills are verified, they will send back a DD or a check. In if the patient is a minor, the in patient's primary caregiver, the father or mother's name. If the patient is a major, it comes in the patient's. So it's a typo, right? The Coal India scheme got repeated in this slide. Can you ignore that? So when we comes at why government schemes are not um, enough spell on, because as I've been telling on our previous slides that often these schemes doesn't cover completely, and the hospital empanelment is a key thing, and also the delays. Often the government schemes have its own logistical delays, and even if there's some issues with the documents, let's say if the ration card is not getting updated or other card is not updated, the income certificate is not proper enough. Often families may not be able to get these government schemes, and then families also have to combine other sources to go ahead. So when it comes to major NGOs, these are some of the NGOs who are right now supporting for bone marrow transplant. Still, I'm telling you, it's all collective, combined effort. The government schemes can provide something, the NGOs can provide, put on their part, like Indian Cancer Society, which is a big name in the country, and even nowadays DKMS, BMST program is supporting for bone marrow transplants. It doesn't have anything to do with empanelment. We have to contact DKMS, BMST program. They will give you a temporary MOU have to be made for each patient, and we can get that. The next one is Veha Foundation, which has very recently started supporting. Before it was called, it was known as MK Hamid Foundation. Now it is called Veha Foundation. They are supporting for all thalassemia patients up to 5. Before initially the approval was more, but now they are giving 5 lakhs per patient, and also for the aplastic anemias, 5 lakhs per patient. And if the patient is requiring more support post BMT, they're giving up to 2 to 3 lakhs post BMT support is provided. Next one is Ekam Foundation Mumbai. So this is an NGO who is providing support for any severe conditions plus BMT as well. And definitely we know the very familiar name UV the Yuvraj Singh Foundation. They also provide support for BMTs. And also Can Kids, which is the biggest name in the country, they are also providing support. They provide special grant supports for bone marrow transplants. And St. Jude's India as well as providing some support, not too much into financial side, but also providing accommodation supports and also. And also from my experience, what I've seen is that the Rotary uh, group and the Lions group. So these two groups have their own regional branches, and they used to provide, like from Bangalore, we used to get a lot of support from Rotary Southwest Bangalore and also the Lions Club. So these are the major groups who can provide definitely support. It doesn't have to be like MPANEL or something. The family, even the family can contact them directly, speak to them. They will provide correct instructions as well as, and they will try to get in touch with the hospital and the treating team with regard to the required documents, and they will provide support. Then definitely they also have some process where what is allocated budget for each year, and also they have the required medical summaries, estimates, and income proofs and ID proofs and protocols, because obviously NGOs gets funds from some CSR initiatives, some donations. So definitely they have to show their utilization. So definitely these documents are a must for all the patients. And even we can combine funds from a couple of the, what I've seen is that none of the NGOs will reject if the patient is already getting support, a partial support from another NGO. So they will we can combine the funds from all these NGOs. And we told about several schemes, state schemes, and NGOs across the country. Now the fourth main element coming is that crowdfunding. We all know that post-COVID, we are all familiar with crowdfunding. So even when I was been working in St. John's in last 6 years, I was fortunate enough to do more than 200 campaigns in various platforms and raised a lot of money for, and some of the major platforms are like Impact Guru, Millap, Ketto, and Give India. So these platforms are very easy to navigate through. Any people, even an illiterate person can navigate that. Just they have to call them. They will have enough support where they will call back to the people. They'll get in touch with the hospitals to get the documents, create a campaign, share the link. All these things will definitely. Usually creating all these links and things will be a huge task for any family from rural areas. Even the urban community will find it a little struggling, but their platforms have huge support, and definitely they provide enough support to give updates to the donors. So these kind of things will definitely help. And when it comes to role of social workers, because often for the even social workers or the BMT coordinators or the counselors who work closely with the families along with the clinical team, uh, we will be able to speak to families and give them proper education and guidance on how to get these things done. That's a major part where all the families should take the help of their BMT coordinator, their social worker, or their counselor, whoever is available in that setting. Please go to them, speak with them, so they can provide definite support to the family. And also they will be able to do the financial assessments and funding support, because assessing a family, doing all this background paperwork, definitely a social worker can help on that thing. And also to coordinate with all this aspect, there will be a lot of teams where billing involves, all this other logistics, there comes accounts, so social worker can do, and also documentation and tracking the patient. So those areas where a social worker helps the families or the BMT coordinator helps, then the the family can have a better travel through during the period of BMT. And when we come to my almost the last slides, where what are the key takeaways of this session? So I know it's a big topic which needs a lot of explanation because families often have unlimited questions. But what, as a social worker or as a BMT coordinator, I can tell is that yeah, it's a costly procedure. It needs a lot of coordination. Government schemes alone cannot support. But can we just wait there and just to blame ourselves? No, we should go out, find government schemes, NGOs, private supports, local supports, and also one of the primary thing will be coordinating all these aspects together, which help the family to go stress free through the process of bone marrow transplant. So that will be my conclusion for this session, where we can tell that BMT funding is not just one single day process. It have lot of aspects to happen in that, where the family alone won't be able to manage all these things, but as a team, the medical team and the support team can do all these things. And also this financial planning should must run in parallel with the clinical planning. It should not happen 1 or 2 days before BMT. It should happen when the time we know that the child is required for a BMT. Let's say it should happen from the time the HLA typing is planned. So that's the time where we can all plan for this thing. And also it needs support from NGO, CSRs, public support, government, all these things. And when we are coordinating all these efforts together among the family, definitely family also have their part. Family plays their role as a system, the care team and the support team. When we all are playing our roles as a small systems, all together it will become a very combined, well running system, which will help ultimately the patient to come out of bone marrow transplant successfully and lead a very successful life. So with this slide, I would like to conclude my thing. I know I had rushed a little bit because a lot of information were there. I hope the sessions were quite helpful, and I'm very happy to take any questions from you. Thank you.
Thank you so much, Mr. Kenson. That was a wonderful presentation. You covered the most difficult and the most challenging topics, uh, right from the need for multiple funding sources to the role of both central and state-driven schemes, and educating us about all the NGOs that are making transplants happen, particularly about central government schemes like the Thalassemia Bal Seva Yojana and BMT Yojana. Uh, Moving forward, we will delve deeper into this discussion with none other than our moderator for today, Ms. Shobha Tuli, ma'am, who has been instrumental in. So, Mr. Neer Samtani, Vice President, Impact Guru, and Dr. Rashmi Malasari, Consultant Hematologist, Pediatric Oncologist, and bone marrow transplant physician from Ramaya Institute of Oncology, Bangalore. Again, Mr. Kenson, I welcome as a panelist, and also Ms. Mansi Nede, the BMT coordinator from Dinanath Mangeshwar Hospital.
Especially Dr. Irtiraz, for giving me an opportunity to moderate this session, which is so close to my heart. And today's topic is, of course, the funding opportunities for BMT. We just heard a very well prepared PPT by Mr. Kansan, and I think he has very in briefly also, and he's put everything in black and white, and I think it's going to be very, very helpful to all our delegates who are attending this meeting. So welcome all of you, and I will be the panelist, as you already know, are Dr. Rashmi Palasari, Mr. Neer Samtani, Mr. Kansan Sam Alex, and Ms. Mansi Nene, who has been already introduced in their slides. And I think they are all very experienced in their own field. So I'll come straight away to the question to Dr. Rashmi, please.
Ma'am,
And
slides are not open in the screen, ma'am.
you can't see it?
Yes, on the screen the PPT is not open.
I can see it on the screen.
Ma'am, it just depends on which screen you have chosen to share. If you can share the.
One minute, please.
Yeah, we can see now.
You can see it now?
Yeah.
Okay.
Yes.
So, So, Dr. Rasmi, welcome once again to today's webinar. So, my first question to you is, what are the ways that you think that, as we all know, you just heard that BMT, a lot of expenses are involved. So, my question is that how can we all, you can think of reducing the cost of BMT starting from the very first test, which is the HLA test?
Yeah. Good afternoon, everybody. I thank the organizers for giving me this opportunity to be a part of this panel. This topic today is also very close to my heart as well, since I work in a organization that caters to patients from lower socioeconomic strata of our community. So thanks, Ms. Shobha, for your question. So this is basically to see where can we cut cost, in bone marrow transplant without compromising on the quality of care. So, talking about HLA, specifically for HLA testing for benign disorders, we have registries like DKMS who actually support free HLA testing for thalassaemic patients with proven beta thalassemia, as well as their immediate family members, that is, their parents and their siblings. So, besides this, when we actually can have MOUs with testing centers, especially government-based testing centers where you can batch samples, institutional rates can be negotiated better to cut down the cost quite a bit on HLA testing. And one more thing that institutions that do a larger volume of transplant can also think of is to have like an internal trust, which is something that we have done at our center, where we have a intra-departmental trust that we can utilize to fund a certain number of HLA testing, provided it is routed to labs that give us quite considerate rates to get the HLA test, because this is that first step of transplant where if we find a suitable match, that itself may sometimes end up being the drive for the families to seek out this life-saving treatment. Besides just the HLA testing, some of the other things that we immediately think about when it comes to cost cutting is, so one thing that I even tell my trainees in the transplant unit this as well, that transplant is that situation where we think every day when we plan things for the next day, what can we not do in excess? So besides not doing things in excess, we also have to still be prepared for some of the unexpected complications that may happen, for which cost can just skyrocket. So when it comes to the earlier parts of transplant, for example, conditioning, we can, so selecting that conditioning regimen is critical. So now we have a lot of published literature where, while maintaining the intensity of conditioning, we can reduce the toxicity, where the cost of the conditioning itself may come down, and a lot of the subsequent complications that you see during and after transplant can also come down. Using biosimilars really help, and this is actually a great thing in India because we have a lot of biosimilars with good efficacy. The significant expense that happens in a transplant happens in supportive care. That is during the transplant as well as in the post-transplant period, especially when complications happen. So, predominantly I'm talking about infections and GVHD. So, having very rigorous infection control practices, both in the inpatient setting and in the outpatient, can reduce the length of the hospital stay, lowering, cost otherwise. Sometimes, you also have to be careful in terms of to do enough so that you don't land in complications. Sometimes, for example, if you don't test for CMV reactivation frequently enough, we may end up getting like a full-blown CMV reactivation before we find out, and then that may add to the cost in terms of finding out a CMV reactivation early on and managing with a lower cost therapy. So it's a very fine balance. And even when it comes to supportive care, for example, and this is something a lot of the centers in India do, is even though the hard set evidence for granulocytes or buffy coat is not fully established in a transplant setting, we know our patients, especially with prolonged, profound neutropenia, the kind of organisms that we encounter are often these multi-drug resistant bacteria. So, empirically giving them buffy coat, or at the earliest sign of an infection, giving them buffy coat granulocytes, which are these WBC infusions, may actually mitigate the patient from going into a full-blown sepsis, or even requiring a lot of higher-end antibiotics for a prolonged period of time.
So, Dr. Rasmi, what I want to get it confirmed from you that when we are talking about the cost cutting, I hope that the protocol and the conditioning regime are not compromised. That's
Correct.
one thing.
Yes. Yes.
Secondly, when you talked about the HLA test, what I understand is that it is done free of cost for the patients, or still there are some charges involved.
No, so if you go through the registries, if you are a registered partner with registries such as DKMS, we can actually get it done free of cost for a certain category of patients. For example, hemoglobinopathies, aplastic anemia patients.
Okay.
Yeah.
So, 1 minute. So my next question is, it's not moving on. Some issue here with the,
Madam, click on the slide once it will
yeah,
move.
of course. So my next question is to Ms. Mansi. And Mansi, that we have spoken on phone also as well. And you have been looking after, there is your 4 years experience there, and there are about 80 to 90 BMTs are already done per year. So my question is, I want to hear from you about your expertise in counseling and coordinating. As we all understand that counseling and coordination is very, very important when the patient reaches the hospital, because if the counseling is not provided in the most proper best manner, then the patient might can get confused. So can you please share your some expertise?
So good afternoon, everybody, and thank you, Shobha ma'am, for the question. So yes, as you said, the counseling plays a very important and a vital role once the patient is recommended to undergo a bone marrow transplant by the physician. So whenever the patient is recommended, the first step they do is the family members and the patients, they do come and meet me. The initial part when the patient comes to me, they have a lot of anxiety, they have a lot of questions and concerns regarding what exactly is the bone marrow transplant or stem cell transplant procedure, and they have a lot of myths because nowadays they start googling and they find a lot of different kind of scary answers to it. So the first and the foremost role as a counselor that I have to do is to make them understand about exactly what they have to undergo during this hospitalization stay. And it starts with explaining them basically what kind of transplant are they undergoing, whether it's an autologous transplant or an allogenic transplant. And I always prefer to have patient, the relatives, the attendant who is going to stay with the patient, and the donor as well during the first counseling sessions, because they each play a very important role, not just the patient but as well as the donor and the attendant who is going to stay with the patient. They should also understand the gravity of the patient, what the patient is going to undergo. So once they are aware about the type of transplant, then I do give them about the pre-transplant evaluation based on what kind of transplant. If it is an autologous, only for the patient. If it is an allogenic, then for the patient as well as the donor. Once they understand the pre-transplant evaluation, then I further explain them about what to expect during the hospitalization stay based on what kind of transplant, what is the tentative timeline of the expected stay, and what are the possible side effects and the complications that they may face during the course of the transplant, and about the recovery phase. So it is divided as a preparatory phase undergoing pre-transplant evaluation, the hospital phase when they undergo the transplant, the procedure, and the recovery phase when they start recovering. And then it various logistics that is involved behind it, because it's not just the transplant, the dietary recommendations, the water intake, and all this various logistic things that are behind the transplant. And once they understand about the transplant procedure, the next thing is the estimation cost, which the physician which provides them about the tentative estimation that is required for the transplant. And that is where I understand how are they prepared for the transplant, what are the funds that they can come up with, and then I get an idea about what rest of the funds that we as a team needs to prepare for the patient. So after the funding is done, after the pre-transplant workup is done, the room availability, because at times there is a waiting period for the patients to undergo the transplant. So most of the time, the counseling session usually happens 1 or 2 months before the transplant, because then they are completely aware what would be the next step that they are going to undergo. And when everything falls in place and the protocols are ready, what conditioning regimen, everything is going to be there, then we finalize a date for the transplant, and then the coordination with the various departments, the blood banks, the labs, the charity department, it all starts once the date is getting finalized. So then there are times when I need to address the emotional and the psychological aspect of the patients and understand the various concerns that they have, and also help them to cope up with the stress and the anxiety that they may are facing during the course of transplant.
I know very well the role of social worker, because I also experienced the same when I was in Pesaro, Italy in 1990s. So when the family comes to you, so you counsel the father, mother, and the sibling and the donor as well as the patient also, or just the donor and the parents and no patient. Patient is not there.
So there are times when the patients are not aware that there may be a case. So, but then we don't use that term. But I strongly feel that the patient should at least understand what the patient is going to undergo during because he is confined it to one room for next, 1.5 months. So the patient should also be mentally prepared, not taking the name of the diagnosis and all if they are not aware, but majority of the time the patients do know what they are suffering. So I do suggest patients should also be there as a part of the counseling, not
Means
just the donor.
once the patient are, above the age of 12 or 14, then perhaps it is better to counsel them separately. What about mud, when you're doing a mud transplant? So do you counsel the donor as well?
Uh,
Or
the
you
for
don't
the
get
mud
a chance?
transplant, yeah, because the identity is also not revealed during the mud transplant, the donor's identity. So the counseling part takes from the registry, the donor registry, they do the counseling part, of
So
course.
very quickly, I'll take another question with you, which is about the gap funding. And we have already heard, about what is gap funding. So just want to know that have you ever tried to collect funds through gap funding so far?
Yeah. So basically, gap funding or the bridge funding is a fund which which cover up the shortfall between the patient's expenses and the fundings that are available. So it's a short fund which will help support the patient to undergo the transplant successfully. So yes, of course, we do take help or support from the gap funding. There are various sources which Mr. Kenson has also discussed. So we do utilize those gap funding sources for our
This
patients.
is, this is quite helpful, when it comes to the shortage of the funds, when there is a crunch and the family is not able to collect funds on their own. So my next question too is Mr. Canson, whom we heard just recently. So in case of complications, I will not go into what kind of complications, we all are aware about it, where the longer stays are needed in the hospital. So what kind of provisions are in place in your center hospital, where the support is given either through the hospital or through some NGO support, or maybe from the patient's pocket?
So thank you, ma'am. Thanks for the opportunity. So when it comes to the longer stay, we all know that any patient entering into bone marrow transplant realm, that's what I'll call it. They have to stay or stem cell transplant, because I found a question from the Q box. Nowadays, it's not bone marrow transplant; it's hematopoietic stem cell transplant. Often the term will bring some bad feelings in among the. That's a very valid question, and thanks for opening and questioning that there. So often during longer stays, like at least for initial 4 to 5 months, we'll request families to stay near to the hospital, because they have to come for frequent follow-up. And definitely being in the southern triangle, we have to take care of the patient from various states, even from the northeast part, from the north part and southern triangle. So for the families, definitely staying in Bangalore, which is a very costly city. Initially, to be very honest, when came to St. John's, we all struggled, because lodging and support was very hard, and we had few uh, philanthropic groups who given couple of beds for families to stay. But then later we were able to get in tie up with Access Life as well as Can Kids Home Away from Home. These two NGOs are now supporting patients from St. John's. Definitely Can Kids is more focused towards children with malignancies, but Access Life is have set up a very good facility near to the hospital to take care all malignant and non-malignant conditions, BMT or non-BMT, provided they will be little more cautious about when it's a BMT child, because post-transplant infections or all these things are in consideration. They will be a little more careful by providing a single cubicle for the patient, the family, and the attenders. And definitely during BMT also, if let's say the patient have to stay more than 4 weeks, 5 weeks, the count recovery is taking more time. Even they are providing free transportation, these NGOs. They will be, so Access Life is having their own vehicle, but CanKids is providing free Ola Uber support. So they will bring the attenders here if they want to go back to the facility to cook some food for the child, because homely cooked food is something that we prefer during this time. This two NGOs have been really supporting, and also St. John's has a in-house annex, which is definitely costing some 350 to 400 rupees per day. But in some special scenarios, when we write a letter to the director have written off the entire cost, where we can't find a room in Access Life or Can Kids, but family can't afford to pay 10,000, 12,000 rupees per month. Even the management was kind enough to provide us that support.
I think you will all agree that the boarding and lodging for the families, is very, very important. As you are aware about Thalassemia Bal Seva Yojana, and there are 21 empaneled hospitals. So some of the hospitals are providing, extra facilities, staying free of cost for that. So that is why I have found that that's our experience, that they prefer, those hospitals where they are given free food and where the boarding and lodging is available there. And you have I must congratulate you. You have a long experience, 6 years of experience in this hospital. So which is something very great, because patients, when they come, they would like to meet the same person again and again. And you have got such a lot of experience. So congratulations to you. You wanted to say
Ma'am,
something?
yeah, sorry, ma'am. Just to add for the point, both these NGOs are not taking any money finances from the family. It's completely free. They are providing free, even some ration as well. Where we have one NGO called Cuddles who provides full ration, some 5,000 rupees, 6,000 rupees worth of ration every month. Plus, these NGOs are not taking any money. So it's zero cost, zero for the food and cooking facilities. Everything is free for the families.
Thank you, Kansan, for bringing this to our notice. So my next question is to Mr. Neer Samtani, and we all are aware about what kind of, health impact Guru has been providing by providing the gap funding to the oncology and to the thalassemia, plastic anemia patients. So my question to you is that when it comes to the economically weaker families, and they are the ones who apply for the gap funding through Impact Guru and the various other crowdfunding platforms. So, can you please explain us a few details about the ones who are not aware about such kind of a funding available in our country? That what is the real current funding pattern for bone marrow transplant patients in our country? And secondly, what's the role of Impact Guru as far as funding for BMT is concerned?
First of all, thank you so much, ISBMT and Shobha ma'am for the privilege to speak on this esteemed panel. There are a lot of experts on the healthcare front. We come and, speak about or help in funding for healthcare. Now we have obviously streamlined ourselves in Impact Guru as healthcare only crowdfunding platform. Now coming down to onco or BMT particularly, see, out of 11 or 12 million cancer patients, I think only are done annually in India. Although it is might be less than 10 or 15% who actually require BMT, and a lot of reasons, because they do not get BMT treatment in India. The biggest reason is the cost barrier, right? Then if there is funding is delayed a lot of times. Sometimes it's also late referrals or distance from the transplant center, which might be the reason. But the funding definitely has a huge potential to cover the ground where BMT treatment is required. Now, if I come and talk about Impact Guru figures, particularly out of all the campaigns that we do on our platform, 19% of them are onco campaigns, and out of that, 10% of them are BMT campaigns, which is a huge number. In fact, the total funds that we raise, at least 16% of those funds raised go to onco and BMT. Now, if we are doing uh, BMT campaigns, there are two categories to it. One is obviously economically weaker section, and other is you know they are well off, but sometimes complications occur even in BMT, and therefore uh,
Well,
I think in
the
Bangalore
voice is
Dental,
breaking.
which
Sorry.
there was
Can
a
you?
case, ma'am, in
Mr. Neil, your voice is breaking.
can you hear me?
Yeah, it's breaking. So I think what you can do is check your connections first. And in the meantime, in the interest of time, can we move to the next question so that Mr. Neil can come back? Can you restart where you stopped,
Sure.
so that we can see if we
I
can.
think, yeah. Can you hear me properly, or is it still
Yeah,
breaking?
now it's better. Go ahead.
Oh, okay, yeah. So as I was explaining that apart from the weaker section, sometimes the middle class or upper middle class might also require funding. Now, if I talk about the BMT, I think we do a median of 4.5 to 5 lakhs per case that we are able to raise. That's a median able to raise for any BMT patient. Of course, there are two types, as I said, one which is DIY, which is do it yourself, so people can come simply use our platform. But the other one is called a marketing campaign where we, use our dollars to able to raise for economically weaker section of the society. And this is where we work a lot with the MSW teams, the coordinators in BMT, and sometimes even the doctors, ma'am.
Yeah, mostly we have seen that when the complications are there at that point of time, the families use your platform to get funding and all that. So, thank you very much, and I'll move on to the next question, uh, which is to Dr. Rasmi again. And my question is that when it comes to the funding, so sometimes it is very urgent, immediate funding, and sometimes it's non-urgent, means the cases could be it could be delayed. So how do you prioritize whether it has been you have to look straight away into how do you manage with that? Are you able to manage for the urgent funding that they require, or it is again, the burden is put it on to the family, or they go back to their relations to collect the money, or is something system is there in place in your hospital where you can look after this urgent funding?
Um, sure. So the figuring out which one is an urgent and which one is a non-urgent case in terms of fundraising, it's basically based on clinical urgency. So it's basically like, the term that we can use is maybe like triage. Triage is something that we use in an emergency room to find out who is the more sick patient who needs a quicker care. So something similar to that, we can have like a triage based on one, the nature of the disease, and two is that window for opportunity for cure. So something that can have a sort of a elective or a planned transplant without urgency. The classic example is thalassemia. So thalassemia, especially thalassemia that is transfusion dependent. So giving thalassemia as an example, because here you have a child who can be maintained in a stable clinical condition by giving monthly blood transfusions, while waiting for funds to come in place to start the bone marrow transplant. And sometimes there are other things that you can do during this wait period to optimize the patient for transplant also. like reducing their iron overload, reducing their HLA allosensitization, those kind of things. Whereas an urgent, and not just thalassemia, there are certain other inherited genetic disorders, certain storage disorders, not all immunodeficiencies, but certain immunodeficiencies where the risk of like a major life-threatening infection is not there immediately. So in all those situations, we can sort of wait in the sense we're talking about, wait for a few months, but not like, years of wait.
Okay.
Now, urgent, unfortunately, a lot of the transplants come in this urgent category. Your classic malignant transplants, that is when you do a transplant for leukemia, or we do transplants for solid tumors like neuroblastomas, lymphomas. So these are all urgent transplants because they have what we call as a narrow window where transplant is the curative therapy and the delay will lead to disease coming back. Now, the second are conditions, typically what we call as bone marrow failure or aplastic anemia. So this is also a situation where a delay in transplant can lead to a fatal infection or, or another severe complication, sometimes bleeding. So these are the ones that require mobilization of funds. So,
sorry to interrupt. We are
Yeah.
really running short of time, so I request all the panelists to be very, very succinct, very, very to the point. We have only 3 to 5 minutes before we can wrap
Got
up this.
got
That's
it.
what I was about to say. And
Yeah.
so please.
So quickly saying, so urgent, non-urgent based on the disease. Then another major factor is also the performance status of the patient. Being that, is this patient fit enough to undergo a transplant so that they have a higher chance of cure, rather than somebody whose performance status is so poor that we are actually quite skeptical about the outcomes of transplant. So this is one way to decide in terms of urgency. And in terms of specifically funds, quicker access to funds is through an NGO or an entity, and a government entity that usually quickly transfers funds within a period of weeks to less than a month. So, government insurances are classic examples. But then things like crowdfunding sometimes hit or
Please
miss.
move on to the next question. Sorry.
Oh, sure, go ahead.
Sorry to cut in.
No problem.
So, Mansi, you have heard about Thalassemia Bal Seva Yojana. So, I don't think so that your hospital is empaneled under this Thalassemia Bal Seva Yojana, but of course, you must be knowing it. So, does your state government provide any funding for BMT? Just very yes or no, and if it is there, so name of the scheme.
So one is there is only one which I know is the Chief Minister Fund, the government fund, and in the Pune city we have Pune Municipal Corporation Fund, PMC fund. So that's the state government fund that is available for BMT as of now.
Thank you so much. So, Mr. Kansan, the challenge is, of course, they have to stay for several months in the city for their treatment. And so, do you help them with the low-cost housing? Any boarding or lodging facilities there?
Yeah, I think, ma'am, that's the same thing where I've explained that before. Like two NGOs. It's the same. Two NGOs who are supporting with free accommodation support and transportation. Thank you.
Thank you so much. And to Mr. Neer again, can you explain us the procedure and the criteria in very short, few lines which a layperson can understand when the people have to apply for funding through Impact Group?
Yes, and there is no criteria to apply for funding if there is economically weaker, where we use our resources to basically run the campaigns. We basically see that if they are socially backward, that is the only criteria that we see. It generally works very well with pediatric cases because of the empathy factor. And the minimum amount that we promise is 25,000 on any campaign that we are running.
Okay, thank you so much. So, Dr. Rasmi, is your institute providing any special financial or any other support to the economically weaker patients other than what has been said earlier?
Other than what Kenson has mentioned, so Chief Minister's Fund, Prime Minister's Fund, and the Ayushman Bharat. So Ayushman Bharat is a tricky situation because some states cover, some states don't cover, some states partially cover. Other than this, empanelment with various NGOs, including, so we have some local NGOs who also support us besides just the nationally prevalent ones, that local, like in the sense like within Bangalore, NGOs who also support. But the key here, what I want to highlight is that to all the social workers and even to patients who are looking to raise funds is it's not always that one person or that one entity that helps you. So what we have to focus is that you can bring multiple players together for one patient and cover the cost of care. And when we talk about cost of care, it's not just the immediate cost of care just for the transplant, but we also have to make sure that there is sustained funding to cover for the post-transplant care. Because it's not enough that we just transplant and then there are no funds left for the post-transplant care. So all the effort that we put into transplant may not come into fruition.
Thank you so much, Dr. Lakshmi. And I think that Tata, one can explore Tata Trust also for the funding also. So to Mansi is with regard to funding sources, do you explore PM funds, PMJ, GAP, corporate funding? Yes or no? We can't hear you, Mansi.
So yes, we do explore PM funds and gap and corporate funding.
So which has been your most successful one, PMJ, GAP or corporate? Yes or no? Which one?
PM, gap and corporate. We
Okay.
don't go for PMJ and ESI.
Okay. So, Mr.
I think
Ken,
this should be the last question that
Yeah.
I can allow on this panel.
yes, of course. So, how do we
Very
train
short
our
answer.
BMT coordinators? You know, you have so much of experience and the social workers to help the patients to reach out to the funding which has been talked about. Be specific
this
and be
a
short.
very simple thing. Open the Google, try for the numbers, one person to another person, like an ice bowl technique. Keep your contacts, update the donors, get the numbers, and also learn from the doctor about little about the disease. And this will help the donors to identify learn more. And one person to another, keep the chain always in touch and give proper updates and regarding the patients. That will definitely help any social workers and BMT coordinators. Thank you.
Fabulous answer. I
Would
think
you
on
like
that
me
note,
to
we should stop.
Or do you want to stop it here?
We should stop, ma'am. I'm really sorry we are out of time.
So I'm
And
sorry
thank
if
you
few
so
of
much.
I'm sorry few of the questions are left, but I apologize due to the shortage of time. But I think we are more or less, we have discussed everything as far as the funding is concerned. Thank you very much for giving me this opportunity to interact with all of you.
Thank you so much, everyone. Dr. Uh, Valsari and the rest of the panelists, our moderators, Subhatuli ma'am, for conducting this very difficult topic very smoothly. And I now hand over for vote of thanks to our newest member of the group, Dr. Santosh Kumar Dedas, Professor and Head, Department of Medical Oncology, Hematology and Bone Marrow Transplant from Ramaya Institute of Oncology. Over to you, Dr. Santosh.
Thanks, Dr. Venkatesh. So it was a great to understand all the perspectives from the social workers, from physicians, from regulatory bodies, support groups. So I thank Kenson, Sam Alex for giving such a great insight into various aspects of funding. Shobha Tuli for wonderful moderation. And Mr. Neer for your insights into how Impact Guru can help. Dr. Rashmi for a physician's perspective of how to go about getting funding, and Mansi for your own different perspective of helping with patients. And I thank the audience for patient listening, and the sponsors Genova and Novartis for helping fund this program. And we look forward to have you all attend the next patient support group series 17 on 10th of January, where we talk about mobility during and after bone marrow transplant during the same time at 3 to 4 p.m. on 10th of January.
Thank you. Thank you very much. Let's meet next.
Thank you. Thank you so
Thank
much.
you. Thank
so
you.
much. Thank you.